The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's go to the diseases of peripheral nervous system and skeletal muscle. So first off, your neuropathies. Pag sinabing neuropathies, we have two types, no? Your axonal and your demyelinating. So your axons are responsible for the signal transmission, no? And therefore, pag pinatay mo ang axons mo, you will have a decrease in your signal amplitude, no, or your strength. But you will have normal conduction velocity. But if you have demyelinating, you know that your myelin is responsible for speeding up, no, the nerve conduction velocity. And therefore, if you have a demyelinating neuropathy, then you decrease the conduction velocity. Okay, so let's start with your Guillain-Barré syndrome. So this is a type of demyelinating neuropathy, and these are the risk factors associated. No, they are infections with the following organisms: your Campylobacter, CMV, EBV, and your Mycoplasma. So this is an autoimmune disease, no, and the body attacks the peripheral nerve components, no, particularly your myelin, no, and because of that, no, nagkakaroon ka ng demyelination. Now, the clinical picture of this is that after an infection, no, a bout of an infection, for example, an acute flu-like illness, then bigla ka magkakaroon ng symmetric ascending paralysis, no, with areflexia, with or without loss of sensation. Now, the problem lies when your respiratory muscles are involved, no? Kasi pagka ganun, kailangan mong ma-hook sa mech vent. Kailangan mo ng ventilatory support. So, ma-admit ka, if a ventilator ka for a while until such time na mag-recover ka, no? Now, for CIDP, kaya ko lang siya nilagay dyan because it's the most common chronic acquired inflammatory peripheral neuropathy. So, the morphology is in keeping with the chronic process. As you can see, meron kang remyelination, no? May evidence ka ng remyelination. And also, the clinical feature is in keeping with a chronic process. So, it's symmetric sensory motor polyneuropathy for at least 2 months. Okay, so it's also a demyelinating neuropathy like your Guillain-Barré syndrome. Okay, now for your diabetic neuropathy, this is a classic example of an axonal neuropathy. No, so DM is the most common cause of your peripheral neuropathy, and you know, in your endocrine system, we have talked about, no, your microvascular disease of diabetes. So anong target niya doon? Kidney, brain, at kidney, nerve, no, kidney, nerve, at saka eyes. Okay, for the microvascular disease. So paano ba na-damage ng DM ang ating nerves? It's because our nerves are also supplied by blood vessels, and therefore you know naman na yung diabetes natin can make our blood vessels messed up, no? So atherogenic blood vessels, and therefore basically magkakaroon ka ng ischemia, no, and that can damage your nerves. Next, your high glucose levels, they're turned into sorbitol using the aldose reductase reaction, no? And your sorbitol is osmotically active and can damage your nerves. Next is in the aldose reductase reaction, since you are reducing something, you need to use a reduced equivalent, no, and have it oxidized, no, in order to reduce the other substance, no? So, ang nangyayari, if you have an aldose reductase reaction, you consume reducing equivalents, no? And those reducing equivalents are needed to protect your cells, no, or your neurons, no, from oxidative damage. And when you do that, therefore, nauubos, no, yung reducing equivalents, and that leaves you susceptible to oxidative damage. So, since this is an axonal neuropathy, then you will expect axon loss, no? And of course, yung vascular pathology of your DM, no, your hyaline arteriolosclerosis. So the most common clinical presentation is your glove and stocking pattern. So distal symmetric, no, na sensory polyneuropathy. Okay, so yung negative symptoms niya, yung wala kang nararamdaman. And then yung positive symptoms niya, meron kang mga paresthesias. And this is because of abnormal discharge, no, from your damaged nerves. And kung wala kang nararamdaman, no, pwede kang makasustain ng wounds. And you know that in diabetes, hindi maganda yung perfusion mo. So therefore, you will have poor wound healing and persistent infections because you are also immunosuppressed, no, to some extent. And basically, ang nangyari niya, you will have a complicated infection. So yun yung mga diabetic foot. Okay? So for Charcot-Marie tooth, kaya ko lang yan nilagay because it's the most common inherited peripheral neuropathy. So basahin nyo na lang siya. Let's move on to your neuromuscular junction diseases. So myasthenia gravis, no, na-encounter natin siya in your chapter 12 because nag-discuss tayo ng thymus, no? So you know that your myasthenia gravis is associated with your thymic disorders. And why is that so? It's because the autoimmunity trigger, no, ng myasthenia gravis ay nandun sa thymic myoid cells. Kaya yun yung nag-explain ng link between your thymic disorders and your myasthenia gravis. So your myasthenia gravis is a type 2 hypersensitivity reaction. So it's antibody mediated against the postsynaptic acetylcholine receptor. So that will clinically present with weakness that gets worse throughout the day. Okay? So habang ginagamit mo yung muscles mo, lalo kang nagkakaroon ng weakness. And most of the time, no, the EOMs are affected, no? So yun, usually yun yung commonly affected na muscle groups. And then in keeping with that fatigable weakness na tinatawag, when you do your electrophysiologic studies, it means that with repetitive muscle stimulation, humihina yung muscle strength mo. Okay? Humihina yung response. Now, this is it's your Lambert-Eaton myasthenic syndrome, and you have encountered this in your chapter 14 in your lungs, no? Because this is a paraneoplastic syndrome of your small cell lung cancer. Now, what happens here is you have your type 2 hypersensitivity reaction, no? So it's antibody mediated then, but this time it's against a pre-synaptic calcium channel. Okay, ulit. Yung myasthenia gravis, it's post-synaptic acetylcholine. Yung Lambert-Eaton, it's pre-synaptic calcium channel. Now, it's because yung small cell lung cancer mo, andun yung trigger mo for autoimmunity, no? The calcium channel in your cancer cells. Nakamukha ng presynaptic calcium channel. Kaya ayun, molecular mimicry din ang peg ni Ateng Lambert. Okay? Now, ngayon, ang pagkakaiba niya clinically, no, yung weakness ng Lambert-Eaton, it improves with activity. And why is that? It's because of your post-activation or post-exercise facilitation. When you do your repetitive contraction, no, ng muscles, magde-develop ka ng increase in calcium, no, in the microenvironment. And that can cause release, no, of your neurotransmitter, your acetylcholine, into the motor end plate, no. Kaya nag-i-improve yung muscle strength mo with exertion. Okay? So, kung EOM sa myasthenia gravis usually affected, in your limbs, it's usually the extremities. And in keeping with that post-activation facilitation phenomenon, if you do your electrophysiologic studies, then you will have an increased response with repeated stimulation. Now, let's go to your inflammatory myopathies. So, pag narinig nyo may inflammatory something, inflammatory bowel disease, inflammatory myopathies, so mga autoimmune yan. Now, let's start with your dermatomyositis. It's the most common inflammatory myopathy in children. But if it occurs in adults, hanap ka ng cancer or tumor kasi usually it occurs as a paraneoplastic syndrome. So basically, ang nadadamage in your dermatomyositis, hindi naman talaga yung muscle directly, no, but it's the blood vessels, and therefore nadadamay na lang yung muscles. Okay? So in terms of morphology, it's mamaya, nasa next slide. So, tingnan muna natin yung clinical features niya. So, syempre, it's a skeletal muscle inflammatory disorder. Therefore, you will have myalgia. And then, the weakness proceeds from proximal to distal. So, for example, shoulder muna and then pababa, no? Sa may fingers. Parang gano'n. Okay? And then, for dermatomyositis, of course, you have cutaneous manifestations like shown here in this picture. So, yung heliotrope rash, ito yung nasa periorbital area. And then, yung Gottron papules, ito yung nasa knuckles. No? And then these are the autoantibodies, so tingnan nyo na lang yan. And for your dermatomyositis, they have better prognosis in children. Now, anong itsura niya morphologically? If you do your biopsy, you will see your perifascicular atrophy. If you look dun sa gitna, malalaki yung muscle fibers, but if you look sa gilid, no, maliliit na yung muscle fibers. So, nandun siya sa labas, no? Yun yung perifascicular atrophy. And also, the inflammation tends to be perivascular and perimysial kasi basically nandun yung mga blood vessels. Okay? And that is in keeping with the pathogenesis na blood vessels yung inaatake ng dermatomyositis and not the muscle itself. Okay? Now, for your polymyositis naman, it commonly occurs in adults and it's a diagnosis of exclusion. Now, it's a T-cell mediated hypersensitivity against the muscle itself, no? And therefore, the muscles are being attacked. So, yung inflammatory infiltrates around the muscle and the atrophy appears patchy. Compared to your dermatomyositis, they don't have cutaneous manifestations, no? Pero pareho sila ng weakness pattern. Now, for your inclusion body myositis, it's the most common inflammatory myopathy in patients more than 65 years old. So, pag matanda at may inflammatory myopathy, ito ang una mong iisipin. Now, remember the autoantibody, no? Baka lang naman itanong, hopefully hindi. So, your CN1A. So, the morphology of this is like your polymyositis, but you have your inclusions. Kaya nga siya inclusion body myositis. The muscle groups affected are different, no? In your inclusion body myositis, usually the quadriceps, so the thighs are affected, and then your distal upper extremity muscles, and even the esophageal and the pharyngeal muscles, which will clinically present with dysphagia. Now, for your muscular dystrophies, no, ang problem is in the dystrophin gene. So, pag nabura yon, no, a total absence, no, that's your Duchenne. Pag meron kang konting activity, that's your Becker. Okay? So, they become symptomatic after infancy at ang nangyayari ay meron kang weakness. And then, meron kang weakness from pelvic girdle to shoulders. And then, dahil doon, magko-compensate yung lower leg muscles mo kaya ka magkakaroon ng pseudo-hypertrophy. And then, eventually, pag nag-late stage ka na ng Duchenne or ng Becker, you will be wheelchair dependent. Now, you also have cardiac and CNS manifestations. It's because dystrophin is also present in the heart and the CNS. Kaya nagkakaroon ka ng mental retardation, cardiomyopathy, and arrhythmias. No. Laboratory findings. Now, your creatine kinase, para siyang reflective of muscle integrity. So, basically, pagka meron kang increase in your creatine kinase, ibig sabihin, meron kang ongoing muscle damage, no? Because you damage your muscles, they release their creatine kinase into the blood. Okay? But for late DMD and BMD, ang nangyayari, mababa yung creatine kinase. It's because wala nang natitirang residual, no? Wala nang residual viable na muscle. Kaya mababa na yung creatine kinase mo. Now, in terms of morphology, no, ng DMD and ng BMD, ito yung late stage, no? As you can see endometrial fibrosis, yung very pink dyan ng mga collagen fibers, and you can see fatty replacement of your muscle, and you cannot see the normal fascicular architecture of your skeletal muscle anymore, no? So this is your end stage muscle. And in keeping with the pathogenesis and etiology of your DMD and your BMD, for Duchenne, you don't have any dystrophin, but for your Becker, you have decreased dystrophin, pero meron pa rin. So, syempre, kapag wala kang dystrophin, mas toxic yung clinical course mo. But if you have dystrophin, kahit decreased, mas compatible siya with life. So, Duchenne is more severe than Becker. Now, for the peripheral nerve sheath tumors, you have your schwannoma. So, your schwannoma, ang genetic defect dyan is your NF2 loss. So, your NF2 is a tumor suppressor gene. And pag sinabing schwannoma, it's a tumor composed of your Schwann cells, no? At ito yung characteristic niya. Meron kang dalawang areas ng tumor, no? The hypocellular, your Anthony B, and the hypercellular, your Anthony A. So, nakikita nyo naman siya dyan sa picture. Tapos, yung dun sa may Anthony A, dun sa may hypercellular, you have these tumor cells, no? Your Schwann cells, na nagpapalisade, leaving anucleate zones, and those are what you call your Verrucay bodies. No, your Verrucay bodies. And this them being Schwann cells, no, they will stain diffusely for S100 or SOX10 because they are neural crest cell markers, no. Now, these are benign tumors. For your neurofibroma naman, it's the most common peripheral nerve sheath tumor, and the defect is a tumor suppressor gene loss din, yung NF1 naman or your neurofibromin. Okay? Ang schwannoma may capsule, ang neurofibroma wala. Ang schwannoma, Schwann cells lang. Ang neurofibroma, aside from Schwann cells, meron siyang CD34 positive stromal cells. And also, as a fibroma, meron siyang collagen, no? And the collagen appears like a shredded carrot. Okay? Now, there are some important forms of your neurofibroma, but I think I will mention yung plexiform, no, the plexiform neurofibroma, because this is the type of neurofibroma that has a high risk of progression into a malignant peripheral nerve sheath tumor, and we will discuss that in the next slide. So this being a neurofibroma, so aside from its positivity to your S100 because of the Schwann cells, the stromal cells are positive for your CD34. Well, it's generally benign, but again, like I said, your plexiform neurofibroma, it's seen in the context of your neurofibromatosis type 1, a familial tumor syndrome, and it's a precursor to MPNST. Ito yun. Now, your malignant peripheral nerve sheath tumor is defined as a sarcoma arising from a nerve or a nerve sheath tumor, or in a patient with neurofibromatosis type 1. Okay? They have complex karyotypes. Pag may complex karyotypes, alam nyo na, aggressive yon, no? Kasi ang gulo-gulo ng genetic makeup niya. Okay? So, it can look like just any other sarcoma, but what's peculiar about your MPNST is that they are capable of divergent differentiation. So, they can differentiate into a lot of things. No? And one of them is your skeletal muscle. No, and this is your malignant triton tumor, as shown here in this picture, no? Yung mga malalaki dyan na cell na bilog, those are your rhabdomyoblasts, no? So if you have NST with rhabdomyoblastic, MPNST with rhabdomyoblastic differentiation, that's your malignant triton tumor, and your MPNSTs are bad tumors, okay? They have an aggressive clinical course and a poor prognosis. Now, for your familial tumor syndromes, these are autosomal dominant, your NF1. So, syempre, NF1 loss yung defect, and that causes increase in your RAS signaling. And you know that RAS is an oncogene, no? And these are your components, no? You can see there your cafe au lait spots and your Lisch nodules together with your other tumors, okay? I will leave that for you to read. And then, your neurofibromatosis type 2 naman, it's for, of course, NF2 loss. So, of course, you will see schwannomas here, as well as your meningiomas, ependymomas, and the other lesions mentioned here. Okay? So, that's for your peripheral nerves and your skeletal muscle. Okay, let's go to central nervous system, another long chapter. Okay? So, sobrang complicated ng CNS path, and therefore kailangan ko siyang simulan with a bit of a very patho thing, no, which is the response, no, of your CNS to injury. So depende sa cells, meron silang different responses. So your neurons, these are responsible for your impulse transmission, and when they're injured, they die. No? So, yung acutely, no, you will have your red neurons. Kaya sila tinawag na red because they're pink, and then their nucleus, no, nag-shrink. Okay, and you will have loss of your nasal substance, but eventually these neurons will be gone, no? Yun yung subacute and chronic response, no? You have your neuronal loss. Okay? Now, for astrocytes, no, yung astrocytes, yung mga surrounding cells natin, kapag may injury, nagpo-proliferate sila, no? So that is what you call your gliosis. And if you are familiar with inflammation and repair, 'di ba? Meron tayong fibrosis. So yung gliosis, siya yung CNS fibrosis. Okay? Parang yun. Okay? Ganun mo siya tatandaan. And it's the most important pathologic marker of your CNS injury. Now, sometimes they can also have atypia in the form of your gemastocytes. No, makikita nyo yan later. And then your microglia, these are your CNS macrophages. So, syempre, macrophage sila. Di ganun din kung anong ginagawa ng macrophage, no? Kung may necrotic foci doon, kakainin ng macrophage yun, kaya mag-aggregate sila around it. Or if you have a dying neuron, mag-ano din sila. Magkokolekta din sila around it para kainin siya, no? So, microglial nodules and neuronophagia respectively. And your oligodendrocytes, these are responsible for your myelination in your CNS. They die also, no? And therefore, resulting in demyelination. So, ito yung example ng acute neuronal injury. As you can see, meron kang red neuron. So, they're very pink and their nuclei, hindi na masyadong malaki, no? Okay, shrunken na siya. Okay, and then yung astrocytes, they can also have atypia, no? So meron silang large, abundant bright pink cytoplasm. So yun yung mga gemastocytes nyo. And then ito, collection of your microglia around your necrotic focus. And yung neuronophagia nyo around a dying neuron. And then this is your gliosis, no? So, proliferation of your astrocytes. And your demyelination, this is highlighted by your myelin stain. So, yung bright blue dyan, yung very blue, yung vibrant, yun yung normal. And then, yung area na lighter, yun yung demyelination. Okay? So, now, that's out of the way. Let's go to the diseases. So, cerebral edema. So, ang cerebral edema, di ba, syempre namamaga yung something. So, in the brain, it will appear as you have flattened gyri and narrow sulci, no? So, mamaya may picture tayo niyan under sa cerebrovascular disorders, no? So, anyway, since you have cerebral edema, basically, nag-increase yung brain substance volume mo, and therefore, that can cause increase in your intracranial pressure, and therefore, para ma-relieve yung pressure, nag-herniate yung mga structures, no? Nag-herniate yung brain mo against your cranial foramina. Okay? So, may dalawa tayong types ng edema, your vasogenic and your cytotoxic. So, yung vasogenic, ang nangyayari sa kanya, increased vascular permeability. And if you recall your chapters 2 and 3, di ba? If you have increased vascular permeability, then magkakaroon ka ng extravasation ng fluid into the interstitial space, no? Kaya ka nagkakaroon ng increase in your extracellular fluid. While your cytotoxic edema, if you recall your chapter 1, the cellular swelling, parang ganun lang din siya. And it happens in generalized hypoxic injury because if you have no oxygen, you will have no ATP, your NAK ATPase pump will fail, and therefore you will have cellular swelling and cytotoxic edema. Okay? For your hydrocephalus, it's defined as increase in CSF within your ventricular system, and the clinical manifestations depend on the state of your cranial sutures, no? Kasi pag infancy, open pa yan, so lumalaki yung ulo nila. But for adults na close na, it causes increase in intracranial pressure because of increase in the volume of your CSF compartment, no? Okay, so ano-ano mga symptoms nun? Headache, projectile vomiting, etc. So we have 3. You're non-communicating, you're communicating. Well, basically, pag non-communicating, there is ventricular obstruction. And therefore, kapag may ganun ka, yung area before the obstruction, magdadilate yon, no? And then, pag communicating naman, ang nangyayari, walang obstruction sa ventricular system, but there is a problem in your CSF resorption. Like in your healed subarachnoid hemorrhage, no, your arachnoid granulations are destroyed and therefore mababa yung CSF resorption. Kaya basically tumataas yung CSF mo within the entire ventricular system, and that will cause generalized dilation of the ventricular system. Now yung hydrocephalus ex vacuo naman, if you have parenchymal loss, no, nagko-compensate yung CSF, so yun yung nag-increase to fill that gap. Now, brain herniation, nabanggit natin kanina, no? Ang nangyayari dito, some portions of your brain, they herniate against your dural folds. Okay? So, in your subfalcine, like in this picture, your cingulate gyrus, no, herniate dun sa may falx cerebri, and yung nandun kasi na structure ay yung anterior cerebral artery, no? And because you compromise your ACA, you will have lower limb deficits. Kasi yun yung nagsusupply, no, dun sa medial area ng brain dito na responsible for your lower limbs. Okay? Now, for your transtentorial naman, the medial aspect of your temporal lobe will herniate across, no, the tentorium cerebelli. And then, yung nandun kasi sa area na yon, yung cranial nerve 3, so maiipit niyang cranial nerve 3, nandun din ang posterior cerebral artery, pati yung cerebral peduncles, kung saan dumadaan yung motor nerves, no? So, ang nangyari sa kanya, you will have cranial nerve 3 defect, no, ipsilateral, visual disturbances because of PCA, disruption or obstruction, and then hemiparesis na either way. Kasi nga, syempre, hindi mo naman makokontrol kung paano yung makokompress, no? Pwede kasi yung IPSI, pwede yung contra. Okay? And in your transtentorial, you will have your Durette hemorrhages. These are your linear hemorrhages in your midbrain endpoints because of the herniation. Okay? Now, yung tonsillar naman, the cerebellar tonsils will herniate sa foramen magnum, and you know, medulla ang makakompress niya, and you know kung anong meron sa medulla, di ba? Your cardiorespiratory centers. Kaya, it will present with cardiac and respiratory depression. Now, let's go to your CNS malformation, starting with your neural tube defects. So, you're the most common CNS malformation, and you know that you need your folate to avoid your neural tube defects. Okay? So, yung spina bifida, ayan, it's the most common neural tube defect. Okay? So, meron tayong close at saka meron tayong open. So, yung spina bifida occulta, di mo kita, no? Kasi may skin overlying the bony defect. So, mukha siyang normal externally. Pero may problem pala dun sa neural tube, no? Pag spina bifida aperta open, so kita mo talaga na may nag-herniate through the neural tube defect, no? If meron kang nag-herniate na meninges, that's your meningocele. Pag may kasamang spinal cord, that is your myelomeningocele. Okay? Pag encephalocele naman, brain tissue naman yung nag-herniate. Okay? Dun sa may ano. And it's common in the occiput. Now, for your cranial dystrophism naman, or your anencephaly, there is a failure of your anterior neural tube closure, and therefore nawawalan ka ng brain, most of the brain and the calvarium. So ang itsura nila parang tapyas yung ulo nila, and then they're left with this rudimentary structure called your area cerebrovasculosa, which is a remnant of your disorganized brain tissue. Okay? For your forebrain anomalies, you have your holoprosencephaly. So, hindi nagsiseparate yung cerebral hemispheres mo. And nagkakaroon ka ng midline defect. So, yan, meron kang cyclopia, no, ganyan. And it's associated with your Patau syndrome, your trisomy 13. And then yung agenesis of corpus callosum, basahin nyo na lang. Let's go to your posterior fossa anomaly, so your Chiari malformations. So, pag Chiari 2, okay, pag Chiari 2, maraming nag-herniate. So, more than one. So, at least 2 ang nag-herniate. Okay? Diba? Like in this photo. So, aside from your cerebellum, you also have your brainstem, your fourth ventricle herniating. No? While your Chiari 1, yung cerebellum lang. So, 1 lang ang nag-herniate. And then, in terms of clinical manifestation, pag mas mataas yung number, mas toxic. So, yung Chiari 2, mas, mas symptomatic agad, no? While your Chiari 1, hindi masyado. Okay? Now, for your posterior fossa anomalies, continuing on, no? Your Dandy-Walker malformation. So, because of the agenesis of your cerebellar vermis, you have an enlarged posterior fossa, no? So, yun. For syringomyelia and hydromyelia, ang hydromyelia, your central canal, no, is dilated, no, with fluid. It's fluid filled and it's dilated. Pero yung syringomyelia, hindi siya yung central canal, no. May something else na nagdilate. Okay? Now, regardless, no, it will compress the anterior commissures, which will cause a characteristic distribution of your neurologic deficits na parang cape-like distribution. So remember the associated disorders, no, with syringomyelia and hydromyelia, okay? Now, for your perinatal brain injury, if you have perinatal hypoxic insults, no, magkakaroon ka ng cerebral palsy. So, motor yung deficits niya. And then, for preterm naman, you can have your germinal matrix hemorrhage and your periventricular leukomalacia. Let's go to your CNS infections. So, pag meningitis, inflammation ng meninges. Pag encephalitis, inflammation ng brain, no? And these are the following routes of transmission. Most common is hematogenous, but there are other routes. So, for your acute pyogenic meningitis, depende sa age group yung most common cause, no? Yung common causes. But the most common overall probably is your S. pneumoniae because it's present in all age groups. Okay? So, the meninges are usually located in the convexities, no? And diniscuss na natin yung morphology nito sa chapter 2, no? Sa chapter 2, yung suppurative inflammation, ang example ko doon ay acute pyogenic meningitis. So basically, because you have a lot of pus, no, in your meninges, pag naghil yan, fibrosis, and that's where the problem comes in, no? Kasi pag nagkaroon ka ng leptomeningeal fibrosis, yung pwede kang magkaroon ng hydrocephalus, no? And then acute aseptic meningitis, pag sinabing aseptic yun, no identifiable, wala kang sa culture, no? Culture negative ka pag aseptic meningitis. So the causes, viruses, no? Other bacteria, no? And rickettsia, autoimmune or chemical. When you have an epidermoid cyst rupturing into your brain, it can irritate the meninges, no? And cause a parang chemical meningitis, parang ganon, no? And then we have your tuberculosis. Now, in tuberculosis, yung exudates ng TB, usually nasa basal cisterns. Ngayon, and around cranial nerves. Kaya nagkakaroon ka ng cranial nerve deficits in your TB meningitis, no? And also, pwede rin siya mag-form ng tuberculoma or a mass space-occupying lesion which can be mistaken for a brain tumor, no? So, alam nyo na naman ang morphology ng TB meningitis. So, syempre, may cacheating granulomas ka. And, of course, pag nag-heal yan, you will have also meningeal fibrosis. So, clinically, of course, these are meningitis. Of course, you will have systemic symptoms, no? Referable to inflammation, infection, plus, of course, meningeal signs like your knuckle rigidity, Brudzinski and Koenig, no? And sometimes when you have brain involvement, then you can have sensorial changes. Okay, so in terms of CSF, tandaan nyo ha, ang pyogenic, no, mababa ang sugar. Okay, mababa ang sugar, neutrophilic ang pleocytosis. For your aseptic, depende kung anong etiologic agent, kung virus, lymphocytes. If it's a chemical peritonitis, then you see your neutrophils. But there shouldn't be a problem with your sugar because wala namang organisms involved na gumagamit ng sugar. And then, of course, there's some degree of tissue damage, no? And you would expect an increase in CSF protein. But of course, the culture will be negative in keeping with its name, no? And then for your TB, no, remember, ang characteristic niya, very, very high protein sa CSF. Now, for your brain abscess naman, ito, isa siyang area ng suppuration, no? And then, ano-ano bang cause ng brain abscess? No, tandaan nyo yung transmission ng CNS infections, pwedeng hematogenous. So, from the heart, no, kung meron kang infectious doon, like if you have infective endocarditis, no, a septic embolus can go to your brain and can cause your brain abscess, no? Mga ganon. So, the rest, self-explanatory na naman. So, the common etiologic agents are the pyogenic organisms, of course, no? And morphologically, you will see a central suppuration, and then yung wall niya, of course, yun yung may repair, no? So, yun yung may gliosis and all that, no? This being a space-occupying lesion that is destructive, no? Therefore, you will have neurologic deficits and increased intracranial pressure. Now, for your syphilis naman, we have 3 forms, no? Can be a meningitis, can be an encephalitis, no, when it involves the cerebral cortex, or can be a spinal cord centered disease, your tabes dorsalis. Okay? For your viral meningoencephalitis, ang tandaan nyo sa herpes, it affects the temporal lobes. And the pattern of inflammation is a hemorrhagic necrotizing inflammation. For your CMV, remember your periventricular calcifications. For your polio, this is a motor neuron problem. No? So, therefore, your anterior horn motor neurons of the spinal cord are affected and they die. Okay? Now, for your rabies, remember your negri bodies. For your JC virus, remember that this is a virus. So, morphologically, you will have inclusions and they affect your oligodendrocytes and therefore will present clinically with demyelination. We're going to discuss that disease later when we go to your demyelinating diseases. And then for your HIV, remember your microglial nodules and your multinucleated giant cells. Now, for fungal, yan, your cryptococcus is the most common cryptococcal infection in immunocompromised patients. For your vasculitis, you have your angioinvasive fungus, no? And then for parenchymal invasion in disseminated candidiasis, no? Invasive candidiasis. And also cryptococcus can cause your brain parenchymal invasion. Now, for your CNS trauma, you have your skull fracture. So, if you know your anatomy, you know that your cranial nerves, they exit through certain foramina in your cranial, in your different regions of your cranial fossa, of your skull base. And therefore, doon magdedepende, no, kung ano, doon magdedepende yung clinical manifestations. For example, if you have an anterior skull base fracture, ang nandun ay cranial nerve 1, so we'll have cranial nerve 1 deficit, no? And then, pag anterior, syempre pwede ka magkaroon ng fracture dito sa may orbit, so pwede ka magkaroon ng Raccoon sign. And then CSF rhinorrhea. Now for central, you know that your extraocular muscle cranial nerves plus your cranial nerve 5, nandun siya, so pwedeng yun yung ma-injure, plus the carotid arteries. And then for your posterior, syempre ang nandun yung spinal cord, no? And the lower cranial nerves. For your temporal, 7 and 8 yung nandun. Plus, you can have your battle sign, which is the ear counterpart of your raccoon sign, no? Okay? Now, for your parenchyma, you have your concussion. So, ang concussion, transient lang siya na neurologic dysfunction. So, usually, usually nagre-recover naman sila. Wala tong organic lesion, no, when you look at the brain. Pero yung direct parenchymal injury meron, no? So, kung blunt yan, contusion, kung penetrating laceration. Well, if you traumatize your brain, syempre, the vessels will be traumatized too. So, you will have hemorrhage, tissue injury, edema, and all that. And then, mag-heal din yan eventually. Now, ganun din yung magiging morphology niya para lang ding inflammation and repair, no? Laging ganun. Para lang ding inflammation and repair. You go back to your gen path. Now, in terms of distribution, if co-injury, kung ano yung side ng impact, yun yung meron. Pag contra-co, opposite the impact. Okay? For your diffuse axonal injury, ano naman to? Mga walang evidence ng contusion, pero comatose, no? At ang nangyari, because of marked changes in your angular acceleration, there is injury to your axons, no, disturbing their axoplasmic flow, and therefore coma sila, no? Pero walang evidence ng contusion. For your traumatic vascular injury, we have your epidural hematoma and your subdural. Ang epidural hematoma usually caused by your temporal skull fractures, no? So the traumatized vessel is your middle meningeal artery. And this being an arterial bleeding, mabilis mag-accumulate yan, no? And that's the reason why mabilis mag-deteriorate ang sensorium ng mga epidural hematoma patients. Now, in the few times, no, na nagiging slow yung bleeding, they will have their lucid intervals. And the lesion here is your lentiform. So, mukha siyang convex lens na hyper-intensity in your CT scan. Sa plain cranial CT scan nyo, puti, dugo, no? So, yun. It's a neurosurgical emergency. Kasi nga mabilis, no? Mabilis ang course nito. So, dapat mabilis ka ding umaksyon. For your subdural hematoma naman, usually extremes of age ang involved. It's because for your babies, no, for your babies, fragile yung bridging veins nila. Kasi yun yung source ng bleeding sa subdural hematoma, the bridging veins. Now, for your adults naman, when you have brain atrophy, kasi matanda ka na, nasi-stretch yung ano nyo, mas magalaw na yung bridging veins nyo, kaya they're prone to tearing kapag nagkaroon ka ng brain displacement. Okay? So, this being a venous bleeding, no, slow ang development ng neurologic deterioration kasi slow din ang rate ng bleeding. Okay? Now, because slow yung rate ng bleeding, pwede kang magkaroon, pwede itong maging self-limiting, no? And pwede siyang maging subdural membrane in the long run. Now, the problem with subdural membrane formation is that meron tong phase na meron siyang granulation tissue and you know na marami yung blood vessels, diba? So, doon ang gagaling yung bleeding sa chronic subdural hematoma, no? Okay? So, sa CT scan, crescent shape siya na density. Okay? Na hyperdensity. Okay, so here, nandyan siya sa may right side ng brain. Okay? Dapat marunong kayo tumingin ng CT. Parang nakalito lang sa una. Okay? So, ano bang sequelae ng brain trauma? Well, if you have subarachnoid hemorrhage, then you will have meningeal fibrosis and therefore you will have a communicating hydrocephalus. You can also have encephalopathy, epilepsy, infections, and psychiatric disorders. For your spinal cord injury, alam nyo naman na depende sa levels ang magiging manifestation nyo. Okay, so use your neuroanatomy for that. Now, let's go to your cerebrovascular diseases. So, ischemia, your brain receives 15% of your resting cardiac output. So, that goes to show na important ang blood, no, and oxygen sa brain. And that is substantiated by the fact that your neurons are the cells most susceptible to ischemic injury in the CNS, no, particularly the specified neurons below. So you know that when you have your ischemia, you will have low oxygen, you will have low ATP, no, and in neurons, it causes a excitotoxicity kasi nag-i-increase yung iyong excitatory neurotransmitter, no, and that increases your calcium, no, in your neurons. And you know, in your cellular injury and death, that your calcium is like a key to a lot of metabolic processes, especially those that involve cell death. Kaya ka nagkakaroon ng cell death. Okay? Now, for your focal cerebral ischemia, well, actually, madali naman yun, no? Anything that can obstruct the blood flow to the brain can cause cerebral ischemia. And kung focal lang naman, of course, focal lang din yung kung ano lang yung obstructed, yun lang ang magiging infarcted. So, basically, parang MI lang din siya. Pero in the context of brain, meaning what's the pattern of necrosis that you see? It's not coagulative kasi CNS ang pinag-uusapan natin. So it's liquefactive, no? And then maghihilang din siya by granulation tissue and then gliosis. So basically it's an MI of the brain, no? Ganun lang naman siya. Okay? And chronic, no, in chronic insults in the brain, there is tissue loss, no? Kaya usually nagkakaroon ka ng mga cavities, no, mga cystic spaces, no, in your brain like so. For global cerebral ischemia naman, well, it means less talaga yung blood na pumupunta sa brain mo, no? Hindi lang siya restricted to a certain part of the brain. So there is no obstruction, there is generalized hypoperfusion, no, in your global cerebral ischemia. And because of your hypoxic injury, no, you will have cerebral edema. And ito yung sinasabi ko kanina na flattened gyri and narrowed sulci. So kapag meron kang hypoperfusion, of course, the most at-risk areas are the watershed areas, no? So, most common dyan yung ACA-MCA border, no? Kasi yun yung mga halos walang, yun yung mga dulo, no? Pag yun yung dulo, syempre, yun yung unang mawawalan, no? Okay? So, depende kung hindi pa masyadong matagal yung insult, no? Pwede pang makarecover siguro yung patient. But if matagal na, alam mo na, malulusaw talaga ang brain niya, no? Kaya magiging brain dead sila. Now, kung tapos na tayo sa infarction, no, punta naman tayo sa hemorrhage. So, ang hemorrhage, may dalawa tayong ang tawag doon? May dalawa tayong patterns, no? Your deep parenchymal, and the risk factor for this is hypertension. Ngayon, ang location ng bleeding nito usually sa loob, no? The deep brain matter. So, usually the basal nuclei, no? For your lobar naman, the risk factor is your cerebral amyloid angiopathy. Mamaya di-discuss natin yung Alzheimer. So, yung Alzheimer na yon may amyloid doon. Tapos yung amyloid na yon, yun din yung nagde-deposit sa mga vessels ng brain, no? And yung amyloidosis, di ba generally nakakatigas siya ng organ? But if it gets deposited in your vessels, humihina yung vessel. And that's the reason why they're more prone to rupture and kaya ka nagkakaroon ng lobar hemorrhage. So sa lobar hemorrhage, medyo superficial yung bleeding. So nandun siya sa may convexities, no? Parang ganon, ng cerebral cortex. Okay? So basically, may hemorrhage, no? May hemorrhage, and then syempre magkakaroon ka ng infarctive changes, no, around, and then basically i-resorb yung hemorrhage na yon, and you will still end up with a cavity, no? Kasi magkakaroon ka din ng tissue loss, and then gliosis, lagi namang ganun. So para lang din siyang infarction, pero may superimposed hemorrhage, I mean in terms of morphology. Okay? And then, let's go to your berry aneurysm. So, yung berry aneurysm nyo, kapag nag-rupture siya, it's in communication with your subarachnoid space. That's why it causes your subarachnoid hemorrhage. So, your berry aneurysms are the most common type of your intracranial aneurysm. No, and it's the most common cause of your spontaneous subarachnoid hemorrhage. So, please take note of the associations, no? Kasi yung mga may connective tissue diseases, yun yung mga prone para magkaroon ng berry aneurysms, no? And also, what's the type of your polycystic kidney disease associated with your berry aneurysms? It's your AD or ADPKD. Okay? So, your berry aneurysms are developmental anomalies, and they're abnormal. No, in such that they don't have smooth muscles and internal elastic lamina, which makes them very weak. No, so they can dilate and they can rupture. The most common site is your ACA junction or anterior communicating artery junction, and nagkakaroon ka ng symptoms kapag nag-rupture siya. And yun yung classically described as your worst headache of your life, no? And then bigla lang silang magkakaroon ng decrease in sensorium, and usually may history ng increase in your ICP, for example orgasm or straining prior dun sa onset ng headache. Okay, now the acute subarachnoid hemorrhage will predominantly present with ischemic symptoms, and that is because when your blood vessels are bathed in blood, no, they become spastic. Okay? Kaya nagkakaroon ka ng ischemic changes, and when you bathe your subarachnoid space with blood, which is rich in fibrin, by the way, and you know that your fibrin is the trigger of your fibrosis, you will have meningeal fibrosis and eventually communicating hydrocephalus. For your vascular malformations, your AVM and your cavernous. So, ang tatandaan nyo lang, for your AVM, marami kang abnormal blood vessels pero separated siya ng brain tissue. While your cavernous malformation, magkakasama siya na vessels pero wala siyang intervening brain tissue. Also, your arteriovenous malformation, high flow lesion. Okay? Kasi nakakonect nga siya sa artery, no? So may may shunting kasi, no? And then yung cavernous malformation, low flow lesion siya. So your AVM is the most common clinically significant vascular malformation, and aside from the bleeding in the brain na nagiging symptom ng AVM, in your kids, no, in your pediatric patients, they can be a significant source of your shunting and therefore high output heart failure. Okay? Now, let's go to your demyelinating diseases. So, ang common presentation ng demyelinating diseases ay neurologic deficits. Ganun lang naman yun, no? Let's start with your multiple sclerosis. It's the most common demyelinating disorder. These are the risk factors, no? There are certain HLA alleles. Geography is a problem, a risk factor. such that if you're farther away from the equator, na wala kang sun, no, risk factor yun for your MS. And that may be related, no, to your vitamin D levels, which is, of course, alam naman natin, stimulated by sun exposure. So it's a type 4 hypersensitivity against your myelin components, no? And therefore, nagkakaroon ka ng demyelination. The pattern of neurologic deficits in your MS is classic, na separated in time and space. Meaning, hindi siya nangyayari ng sabay-sabay and iba-ibang systems yung involved, no? So magulog siya, okay? It's temporally and spatially heterogeneous, okay? So these are some classic clinical manifestations. You have your unilateral visual loss, gawa ng optic neuritis as a common initial manifestation, and you have your Jacksonian seizures, okay? Now, the others are minor. So, pag NMO, the defect is your anti-aquaporin 4 antibodies. No, and it destroys your astrocytes. And nadadama yung oligodendrocytes kaya ka nagkakaroon ng demyelination. So, kaya siya neuromyelitis optica, myelitis optica. So, bilateral visual impairment plus myelitis, so may spinal cord manifestations ka, no? Pwedeng weakness, pwedeng dysautonomia, and they happen synchronously, so sabay. Now for ADEM, ang ano naman sa kanya, post-viral infection, no? And then ang symptoms mo ay more of sensorial changes. Okay? And then for your CPM or your central pontine myelinolysis, ito yung associated with osmotic stress. So, ang i-elicit mo dito is rapid correction of your hyponatremia and then bigla kang quadriplegic, no? And then for your progressive multifocal leukoencephalopathy, ito yung kinokos ng JC virus, no? So, ang ano dito is immunosuppression. So, pwedeng AIDS, pwedeng transplant. Now, for your neurodegenerative diseases, okay? So, ang main story ng neurodegenerative diseases is there is an abnormal thing that accumulates inside your neurons, no? And that abnormal protein will trigger an unfolded protein response or elicit an inflammatory response, which leads to the death of that neuron, no? And basically, neuronal loss, no? And of course, the carnage left behind by that pathologic process will be observed in the form of gliosis. Now, in the surviving neurons, they will of course harbor the inclusions. And that's the reason why yun yung holy trinity ng findings na nakikita mo in your neurodegenerative disease. Okay? So, the clinical features of your neurodegenerative disease will depend on the anatomic area involved. So, for example, cortex, andun yung thinking natin. So, dementia, and memory, personality. So, dementia tayo. Your basal nuclei will control your fine motor outputs and therefore you will have EPS, no? Extrapyramidal symptoms. Your cerebellum, if affected, you will present with ataxia. And for your motor neurons, you will have weakness. So, let's start with your Creutzfeldt-Jakob. So, this is prion-related. So, yung prion, no, it's an abnormal protein that can propagate and spread and recruit other normal proteins to become abnormal as well, no? So, yun yung nangyari sa kanya. Now, this one affects the cerebellum and the cortex, no? So, you will have dementia, no? You will have dementia and ataxia. Mga ganon. Okay? Now, the characteristic lesion in your Creutzfeldt-Jakob is your spongiform transformation of your brain. So, here, ang dami mong butas-butas, no? And you have your choroplaques that are composed of your prion protein. Okay? Now, for your Alzheimer naman, it's the most common cause of dementia in older adults. Remember your trisomy 21 and its association with your Alzheimer's. It's because your APP gene, no, yung amyloid precursor protein gene is in trisomy 21. Now, meron pa yung mga ApoE gene polymorphisms, no, associated din siya with the development of your Alzheimer disease. This being a dementia, of course, your frontal, temporal, and your parietal areas, no, lobes are affected, no. So yun yung mga nag-atrophy. And of course, in terms of morphology, ang tatandaan nyo si neuritic plaques and your neurofibrillary tangles. So for your neuritic plaques, it's composed of your beta amyloid. Yung neurofibrillary tangles nyo yung tau. So alin yung specific for Alzheimer? It's the neuritic plaques. Pero alin yung nagko-correlate sa degree ng dementia? It's your neurofibrillary tangles. Okay? So, because the cortex is affected, the presentation is dementia. No? For your peak disease naman, it's part of what you call your frontotemporal lobar degeneration, no, or frontotemporal dementia. Ang pinagkaiba nila sa Alzheimer's, usually younger yung onset ng dementia, no, compared to your Alzheimer's. And then also, meron kang personality and behavioral changes preceding the dementia. So here you can see a frontal atrophy, no, in your peak disease, and you have your peak bodies composed of your tau. Okay? For Parkinson naman, ang important association sa kanya ay yung Gaucher disease. Binanggit ko na yan nung chapter 4, no? And then also, nakakita tayo ng post-encephalitic Parkinsonism nung influenza 1918 pandemic. So the defect in your Parkinson disease is the loss of dopaminergic neurons in your substantia nigra. So nagiging pale yung iyong substantia nigra, and nagkakaroon ka ng Lewy bodies. So yung Lewy bodies, that is composed of your alpha synucleate. So pag ang ina-affect nito ay basal nuclei. So ibig sabihin extrapyramidal symptoms yung meron ka. So more of a movement. Okay? And ito yung Parkinsonism, no? So you have mask fascies kasi you have diminished facial expression, kaya parang mask daw. You have slowed voluntary movement, rigidity, pill rolling tremor. So yun yung mga classic ng Parkinsonism. Now you can also have dementia in your you can also have a dementia component, and when that happens, you call it dementia with Lewy bodies. So you also see your Lewy bodies not just in your substantia nigra, but you also see them, no, in your cortex. For your Huntington naman, this is the only neurodegenerative disease na i-discuss natin here na purely heritable, no, na purely heritable. So it's a trinucleotide repeat disorder. So you have a CAG extension in your Huntington gene. So you will produce a an abnormal Huntington protein that will accumulate in your neurons, and of course the general pathogenesis of your neurodegenerative disease. Ang ina-affect ng Huntington ay cortex and striatum. So cortex and basal nuclei ang kanyang presentation. So, pag cortex dementia, dun sa basal nuclei, you have your chorioathetosis. Okay? For your Friedreich's ataxia naman, ang characteristic nito ay ataxia cardiomyopathy, no? Ataxia cardiomyopathy and also diabetes because it affects, no, your pancreatic beta cells. Okay? So this is also a trinucleotide repeat disorder, GAA naman in your frataxin gene, and which causes low frataxin. And apparently this is important in the normal function and maintenance of these the following cells, no, your neurons, your cardiac muscle cells, and your pancreatic beta cells, kaya sila namamatay. Okay? So, yon, ataxia cardiomyopathy and DM. And what pattern of cardiomyopathy for Friedreich's ataxia? It's your hypertrophic cardiomyopathy. And then, for your amyotrophic lateral sclerosis, ang nangyari naman dito, ang inaatake ay, your motor neurons. And therefore, you will present with weakness, no? So, here you see your Bonina bodies, no? Here, highlighted by the arrowhead. And also some inclusions composed of yung abnormal TDP-43. Kasi yun yung nag-accumulate dun sa amyotrophic lateral sclerosis. So yun, basically motor ang kanyang manifestation. As you can see here, weakness, 'di ba? Respiratory muscle involvement, extraocular muscle involvement, and all that. Okay? So, ito, basahin nyo na lang yung sa toxic and metabolic disorders, no? And then, let's go to tumors. Okay? So, tumors. Your tumors are space-occupying lesions. They basically increase your brain volume, no? In terms the volume occupied by the brain. because they're space-occupying lesions. And therefore, you will present with increase in intracranial pressure, no? And also, because it can destroy and compress, no, the surrounding parenchyma, you can have neurologic deficits. It's also accompanied by an inflammatory activity, no? And because of that, the surrounding brain area will be affected, no? And therefore, you can have decreased seizure thresholds in those areas. Kaya ka pwedeng magkaroon ng seizures. Now, aside from the tumor, no, itself being the cause of increased ICP, if you have tumors in your posterior fossa, which can obstruct your ventricular system, then you can have an increased ICP because of hydrocephalus, no? Also because of hydrocephalus. Now, in terms of prognosis, your tumors, they are graded, no, by the WHO from 1 to 4, with worsening prognosis with increasing grade. And also, the site dictates the prognosis of a tumor, no? Kasi syempre, if a tumor occurs at a very critical site and kahit benign yan, pero nagkaroon ng mass effect in a critical site, then medyo pangit ang prognosis niyan. Okay? Location is everything then. So let's start with your adult type diffuse gliomas. So your gliomas are the most common group of your primary brain tumor. So yung mga gliomas, the glial cells, no? The neuroglial cells, yun yung nagpo-proliferate. So the most common type of glioma is your astrocytoma, the one that is derived from your astrocytes. No, and pag sinabing diffuse glioma, these are infiltrative. So they're not well circumscribed masses. So they are infiltrative masses on neuroimaging. So first off, we have our astrocytomas. Now, this is where it gets complicated because hindi na talaga simple ngayon ang classification ng CNS tumors, no? We're going more towards genetics. So I feel like I have to update you on this, no? Well, yung basic principles naman hindi naman nag-iiba, but alam mo yon, semantics, okay? So, astrocytoma IDH mutant. So, therefore, they should have IDH1 and IDH2 mutations. Now, your astrocytomas can be from grades 2 to 4, no? Depending on how cellular they are, how atypical they are, no? How many the mitosis is, and kung meron ka bang necrosis and microvascular proliferation. No? So here in our example, we have a grade 3 astrocytoma. So assuming that this is IDH mutant, no? So as you can see, pag grade 3, ang dami niyang cells, may atypia ka, and you also have conspicuous mitotic activity, no? But you don't have your necrosis and your microvascular proliferation. Na ipapakita ko yung example mamaya sa glioblastoma. Okay? So the prognosis, of course, pag it worsens, no, with increasing WHO grade. And in your astrocytoma IDH mutant, no, if you have these genetic abnormalities, automatically you are classified under CNS WHO grade 4 because poor prognosis na sila, no? Kaya doon na sila nakalagay. Okay? So for oligodendroglioma naman, ang kailangan mong tandaan, meron silang IDH mutation and you have 1p19q co-deletion. Okay? And the characteristic keyword for, the buzzword for this is your fried egg. So you have your round cells with your round central nucleus, no? Very low grade yung appearance, parang very monomorphic. And then if you look at this, meron siyang mga chicken wire vessels, no? Yan, nakalagay dyan sa picture. And then, another characteristic fact ng oligodendroglioma, isa siya sa mga brain tumors na merong calcifications. Okay? Now, let's go to your glioblastoma. So, dati, ang astrocytoma, pag CNS WHO grade 4 siya, ang tawag sa kanya ay glioblastoma na. Ngayon, hindi ganon. Okay? So, pagka astrocytoma ka na IDH mutant at grade 4 ka, ang tawag sa'yo astrocytoma IDH mutant grade 4. Okay? Pag ikaw ay walang IDH mutation, that is the time where you use your glioblastoma name. Okay? So it's a glioblastoma IDH wild type. Okay? It's the most common primary malignant brain tumor in adults. And grade 4 ang morphology niya. So, it's a malignant astrocytic tumor with your necrosis na pseudo-palisading. Parang nakapalibot siya, no? Binoborder niya yung necrotic area, and microvascular proliferation, such as this example, no? So, you have endothelial cell proliferation. So, yan yung tinatawag na microvascular proliferation. So, pag meron kang isa niyan in a high-grade glioma, no, na astrocytoma, na wala kang IDH mutation, glioblastoma yun, na IDH wild type. Okay? And the prognosis is, of course, CNS WHO grade 4, very poor, no? Now, for your circumscribed astrocytic gliomas, we have our pilocytic astrocytoma. Okay? It's the most common glioma in children, and the usual imaging finding is a well-circumscribed solid lesion or a cystic lesion with a mural nodule. Most common site is your cerebellum. So, morphologically, you will have this biphasic architecture. So, you have your dense fibrillary areas, like here in your asterisk, yun yung mas mapula. And then you have your light areas, no? Yun yung loose na microcystic areas. And you see your rosenthal fibers, like in your large arrow, and your eosinophilic granular bodies. Okay? And of course, this is WHO grade 1, so the prognosis is favorable. Now, for your ependymoma naman, remember na associated siya sa NF2. Okay? Sa neurofibromatosis type 2. Okay? These are well-circumscribed solid masses and they vary in location. Pwede silang supratentorial, pwedeng posterior fossa, or pwedeng spinal. So for children, usually they're intracranial. So pwedeng supratentorial or posterior fossa in the fourth ventricle. And in adults, usually they're in the spinal cord. No? So basically, you have cells with long cytoplasmic processes, no, na nagfa-form ng cell-free zone around a vessel. And that is your perivascular pseudo-rosette. Okay, so yun yung mga nakikita nyo in your ependymoma. Yung medulloblastoma nyo naman, it's the second most common primary malignant tumor in your children following your pediatric diffuse high-grade gliomas. Okay? Yung other types ng medulloblastoma, associated siya with your nevoid basal cell carcinoma syndrome or your Gorlin syndrome, no? So these occurs characteristically in the cerebellum, and this being a medulloblastoma, if you recall your chapter 6, then you have your small round blue cells again, no? Now these are highly malignant tumors, but they're radio sensitive. Okay? For your meningioma naman, yung mga brain tumors na diniscuss ko, lahat yon nag-arise yon within the neuraxis, within your brain or your spinal cord. And we call them intraaxial tumors. Pag naririnig nyo yun sa CT scan, no? Ay, may intraaxial ba yan? Extraaxial ba yan? Okay? Now, your meningioma, sa meninges yan, no? Sa meningothelial cells. And therefore, it's outside of the neuraxis. It's outside the brain. It's outside the spinal cord. And therefore, you have an extraaxial mass, no, in your neuroimaging. And since meningioma yan, nakakabit yan sa dura. So, it's an extraaxial dural-based solid mass with your dural tail. So, it's also associated with your neurofibromatosis type 2, like your ependymoma, no? There are many morphologic patterns of your meningioma. So, i-discuss ko lang yung mga common, your meningothelial and your psammomatous. But here we have a meningothelial meningioma with a bit of psammomatous, with a bit of psammoma bodies in it, no? So, gandang example nito kasi makikita mo na. Okay? And then you have your primary CNS lymphoma. It's the most common CNS tumor in your immunocompromised patients. Again, most common type is your DLBCL. And your METS is the most common brain tumor in adults. And therefore, when you have a brain mass, you rule out METS first. Okay? And then lastly, we have your tuberous sclerosis complex. Marami kasi tayong na-discuss na familial tumor syndromes na. So, ito na lang yung natira na hindi ko pa na-discuss, no? Kaya, ito lang yung laman nung sa chapter na to. So, this is an autosomal dominant disorder. So, it involves the loss of function of your tumor suppressor genes TSC1 and TSC2, which can cause the following abnormalities. Okay? And that ends your CNS. Okay. Kung kasama nyo pa ako hanggang ngayon, thank you talaga. At least hindi na sayang ang aking vocal abuse. Okay? So, let's start, no, with the eye, the end. Ooh, Diyos ko. Okay, so orbit. For orbit, we have our proptosis. So, pag proptosis, it's your forward displacement of your eye. So, lumuluwa yung mata mo. Yun. Okay? So, there are two types, no? You have your axial. Ito yung lumuluwa ng pa-forward or positional. And your positional, it depends kasi on the surrounding structures. Baka may pathology doon. Now, for your axial proptosis, if you see here in this picture, yung mga extraocular muscles nyo, meron silang cone na pinoproduce. Now, if there are mass lesions within that cone, then that can push your globe, no, forward. So, example are your optic nerve tumors like your gliomas, meningiomas, and even Graves' disease, kasi yung mga soft tissues dun sa orbit na dun sa may cone, yun yung nagpo-proliferate, kaya parang napupush niya rin forward. Now, for your positional, this is your lacrimal, for example, if you have lacrimal gland tumors, no, you know that your lacrimal glands are in your upper and lateral, no? So, upper and lateral. So, pagka ganyan, pag lumaki yan, magkakaroon ka ng inferomedial proptosis. Okay? So, orbit inflammation, it can be caused by your infections or your autoimmune diseases like your Wegener's, no? Now, for your tumors naman, the most common tumors of the orbit are your vascular tumors, your most common primary, no? Now, for your eyelid, you have your calasion, no? And you have your hordeolum. So, kakalito talaga yun, no? Anyway, ang difference ng hordeolum at ng calasion, your hordeolum is an infectious process, while your calasion is not. Okay? So, ang hordeolum is an infection depending if it's in the external or if it's an external or an internal hordeolum. Pag external, it's something that involves the lash, no? So, it's either the eyelash follicle itself or the glands surrounding the eyelash follicle, no? Your glands of size and mole. Infection nung mga yon. Okay? Now, for internal hordeolum, it's the meibomian gland. Pero infection, again, like I said, infection. Now, calasion is non-infectious. Okay? So, it's, the cause is obstruction. So, when you have obstruction, then basically, matatrauma mo yung duct, no? And you will have extravasation of your lipid and magkakaroon ka ng granulomatous reaction. Kaya ka magkakaroon ng tinatawag na lipogranuloma. Now, because it's in the lid, one differential diagnosis would be your sebaceous carcinoma. But the most common malignancy in the eyelid is basal cell, no? And as you have learned in your skin chapter, your basal cell has negligible metastatic potential, but your sebaceous carcinoma, which is also a common tumor in the eyelid, has significant metastatic potential. Now, for your conjunctiva scarring, so usually naman, yung mga cases natin ng conjunctivitis, hindi naman sila nagsascar. Kasi kung hindi siguro, bulag na tayo lahat. Charot. Okay? So, ang nangyayari kasi, when you have select pathogens, for example, your chlamydia, no? Yung chlamydia trachomatis, yan, very, very notable yan in causing conjunctival scarring. Now, what is so bad about conjunctival scarring? It disturbs your tear film, no? Yung process ng pag-adhere ng tear film, no? Nadidisrupt siya ng scarring, and therefore, you will have dry eyes. Okay? Now, for pingecula and pterygium, now, itong dalawan to, ang risk factor dito ay sun exposure, no? So, sun exposure. And, ang pinagkaiba nila, no? Yung pingecula, hindi siya nagka-cross dun sa cornea. Ang pterygium, nagka-cross siya. And therefore, pterygium can present with astigmatism. These growths, you have to biopsy, no? Because you have to rule out related, no, malignancies, no? Related to actinic damage like your squamous and your melanomas. Okay? So remember, alin ang may astigmatism? It's the pterygium kasi yun yung nagko-cross ng cornea. Now, for tumors, the most common tumors of the conjunctiva are your squamous and your melanomas, and they commonly arise in the limbus. Now, for your sclera, sclera is notably poor in terms of wound healing because it has low blood vessels and low fibroblasts. And if you have learned in your chapter 2, you need those, no? You need your perfusion and you need your fibroblasts there in order for them to heal. Okay? So it can be affected by your rheumatoid arthritis. no, it can cause necrotizing scleritis. You can have blue sclerae, no, when the sclera is thinned and your uvea gets see-through, no, your uvea is seen through your thinned sclera. So yon, which is it can also be a part of your osteogenesis imperfecta because of the defect in your collagen, kaya nagiging ano yung sclera mo, nagiging thin, no, and some other conditions that are listed there, no. So this is an example of your blue sclera seen in your osteogenesis imperfecta. Now, keratitis. These are the etiologic agents. Well, HSV is very glaring. So, regardless of the etiologic agent, you know that in your inflammatory disorders, there is breakdown of your collagen. So, if there's increased collagenase activity, you basically destroy your cornea, no? And when you and the carnage of that destruction, no, can be seen as a pus accumulating in the anterior chamber, and you call that hypopyon. Okay, now your HSV, no, can cause ulcers in your cornea, like so. Now, for your keratoconus, this is an interesting thing, no? So, it's associated with your Down and your Marfan syndrome, and it's also associated with your atopy, no? And the thing is, pag yun ano pala, yung pagkakamot pala, no, yung pag-rub pala ng eyes. Okay? Yung pag-rub pala ng eyes can cause your keratoconus. And feeling ko yun yung dahilan kung bakit ako may astigmatism. Kasi yung mga atopic individuals, usually sila yung nagti-tear up, 'di ba? Pag na-expose sa allergy, and then parang ang kati-kati ng eyes nila, no. Namin, atopic pala ako. So, yun, siguro kaka-chronic rub, no? Kaya ka nagkakaroon ng abnormalities in your cornea which can clinically present with your astigmatism. So yon, keratoconus pala yan. So feeling ko na ipaliwanag ko na kung bakit talaga astigmatism ay parte na ng buhay ko. Yun, mukhang may kinalaman siya sa pagiging atopic ko. Anyway, moving forward. Your cataract naman for your lens, diba? It's lens opacification. There are a lot of causes. No, your galactosemia, your DM can cause cataracts. No, Wilson's and your steroids, okay? And even age, no? Senile cataracts, okay? Ang senile cataracts, meron siyang impaired perception of blue color because of the brown discoloration of your lens due to your urochrome pigment deposition. Now, for glaucoma, glaucoma is defined as diseases characterized by distinctive changes in the visual field and your optic nerve cup. So, pag narinig nyo yung glaucoma, usually ang kasunod ay increased intraocular pressure. So, dito, ang pinagkaiba, meron kang open angle and angle closure. So, pag open angle, walang obstruction dun sa pathway ng flow ng aqueous humor through the trabecular meshwork. Pero pag may closed angle ka, merong obstruction dun sa mismong pathway. Okay? So, example ng angle closure, pag merong nakabara dun sa trabecular meshwork itself. Pero walang problema dun sa pathway, no? But for your angle closure yon, yung mismong pathway can be obstructed by something, no? And because of that, may increase yung intraocular pressure. Okay? So, for endophthalmitis and panophthalmitis, so pag endophthalmitis, it's the vitreous humor that's inflamed, and then pag kumalat na yan, up to the orbit, that's your panophthalmitis. So, basically, pag acute inflammation, no, you see your exudates, and then when they heal, you will have your fibrous adhesions in the form of your synechiae. Now, depending on kung ano-ano yung mga nagdidikit-dikit, no, na structures, magkakaiba-iba ang clinical presentations, and these are listed there, no, in your handouts. Now, for uveitis, no, it can be infectious, no, or non-infectious, like your autoimmune diseases. For example, no, your reactive arthritis, di ba, yung can't see, can't pee, can't climb a tree, and also your Behçet syndrome. Now, for your tumors, the most common intraocular malignancy in adults is metastasis to the choroid, no? Because choroid is one of the most richly vascularized tissues in the body. But for the most common primary intraocular malignancy in adults is uveal melanoma. And unlike your cutaneous melanomas, your uveal melanomas are not associated with your UV exposure. And also, they have different genetic mutations, no? compared to your cutaneous melanomas. Okay? So, wag na munang anuhin yung ibang morphology kineme. Basta kapag may uveal melanoma ka, the most common site of distant mets is the liver. So, ibig sabihin, kung meron kang metastatic melanoma to the liver, imbestigahan mo ang mata. No? Yun. Now, let's go to your retina. Ito na, madaming fundoscopy pictures. For retina and vitreous, first off is your ret-detch. So, your ret-detch, meron siyang dalawang types, no? Your regmatogenous and your non-regmatogenous. So, your regmatogenous, you have a full thickness retinal defect where the vitreous dissects through. Tapos, paghihiwalayin niya yung neurosensory retina from your retinal pigment epithelium. For your non-regmatogenous retinal detachment naman, you have an exudative disorder, no, na nagkakaroon ng accumulation ng exudate between your retinal pigment epithelium and your neurosensory retina. At any rate, na regardless, you separate your neurosensory retina from your retinal pigment epithelium, and this is an ophthalmologic emergency. No? This can cause your visual loss. Okay. Now, for hypertensive retinopathy, you know that in your hypertension, you have hyaline arteriolosclerosis, no? So because of that, decrease yung blood flow, no? Decrease yung blood flow to your arterial vessels, and therefore nagkakaroon ka ng copper wiring kasi walang lamang dugo, no? Yung vessels mo. So nakikita mo yung outline lang ng vessels. Okay? Now, those vessels are kumakapal, no? Yung mga arteriolosclerotic arteries. And therefore, kapag nagmi-meet sila or nag-intersect sila ng vein, naiipit niya yung vein. And therefore, yung vein, hindi siya makadrain ng blood. So, you will have retinal venous stasis and occlusion. Well, if you have impaired venous blood flow, that ultimately impairs your oxygenation of your retina. And therefore, you will have infarcts in your nerve fiber layer. No? And your axons will be swollen, and eventually this will present with cotton wool spots on your ophthalmoscopy. And then for malignant hypertension, you have the following disorders. No, your L-Schnig spots, which are from infarcts, no, from choroidal vessel damage, and your non-regmatogenous retinal detachment. If you have such high pressure, no, in your vessels, then madali ka talaga magkakaroon ng edema and exudates. Okay? Now, for your diabetic retinopathy, it's the most common retinal vascular disease. The most reliable indicator of DM in the eye is in the ciliary body. You have to examine the ciliary body. But let's focus on the diabetic retinopathy. So we have two types. Now, your non-proliferative and your proliferative. Okay? So basically, you recall, no, kung ano yung vascular pathology ng diabetes. So your diabetes, they have hyaline arteriolosclerosis and they have leaky capillaries. And you know when you have leaky capillaries, recall your chapter 2 and 3, no? Magkakaroon ka ng edema. So magkakaroon ka ng edema, ng exudates, no? And if you have retinal arteriolosclerosis, you will have impaired the blood flow, and therefore that leaves your retina ischemic. So you will have ischemic retinal damage, macular edema, and your exudates. You also have microaneurysms, no? Now, kapag may retinal ischemia ka na, that triggers the production of your VEGF, your vascular endothelial growth factor, and therefore you will have neovascularization, no? That neovascularization will form a neovascular membrane, and that can cause traction retinal detachment, no? Traction retinal detachment, some fibrous adhesions, and all that jazz, no? And yun yung hallmark ng proliferative diabetic retinopathy. It's the neovascularization. Now, continuing with our vascular diseases, we have our RAO, or your retinal artery occlusion. So, these are the causes, no? Atherosclerosis, pwedeng may nakabara dun sa central artery or sa branch, no, ng retinal, sa branch retinal artery, no? A thrombus or an embolus. Okay? Pag branch siya, iba yung manifestation niya, segmental infarction lang. But if you have central retinal artery occlusion, the retina is diffusely pale, no? Syempre central no? And of course, that accentuates the cherry red spot in your macula, as you can see here in this picture. Now, your CRAO is an ophthalmologic emergency. So, dapat ma-diagnose nyo agad yan and madala nyo kaagad para ma-relieve yung ischemia, no? Ma-resolve nyo agad yan kasi mawawalan siya ng vision. Okay? Now, for your RVO, it's the second most common retinal vascular disease. So, these are the etiologic these are the etiology, no? And for the types, you have your ischemic and your non-ischemic. And if you recall your proliferative and non-proliferative diabetic retinopathy, parang medyo ganun din siya. So for ischemic, it's the neovascularization. It's because if you have retinal ischemia, you will have VEGF production, which results in neovascularization. But for non-ischemic, you have leaky capillaries, and therefore, para siyang proliferative DM retinopathy. And because of that, you will have hemorrhages, you will have exudates, and on the background of your vasculature. And that is the reason why it's called a blood and thunder appearance. Okay? Now, for your retinopathy of prematurity, we've already discussed that, no? Na kapag nag-hyperoxic therapy ka in your neonatal RDS patients, for example, no, ang nangyayari niyan, the immature peripheral retinal arteries will constrict, and that can cause retinal ischemia. When there is ischemic retinal damage, you will have vascular endothelial growth factor production, and therefore it causes neovascularization. So yun yung ROP. So that is retinal arteries, not renal arteries, okay? And then for your degenerative diseases, your AMD, you have two types, no? Your dry and your wet. So for your dry, D is for drusen. So you have Brock membrane deposits, and these are called your drusen. So walang neovascularization for dry. Pag wet naman, meron kang neovascularization. Now for your retinitis pigmentosa, it's an autosomal dominant or recessive or X-linked recessive. So it's a genetic disease, no? At ang nangyayari dyan, your mutations will eventually cause death of your rods and cones. So basically yun, mawawalan ka ng ano bang function ng rods, no? Usually for night vision, no, your cones for colors, diba? So basically yun yung clinical manifestations mo. And kaya siya tinawag na retinitis pigmentosa, it's because meron kang pigment deposition in your retina. So yan, like so. Now for your tumors, your retinoblastoma, it's the most common primary intraocular malignancy in infants and young children. So alam nyo naman yung RB, di ba? Yung retinoblastoma. Diniscuss natin yan in your chapter 6. It's in chromosome 13. No? So for heritable cases, they have a germline mutation, and therefore they just need one somatic hit, no, in order to present with a tumor. Or kung sporadic, dalawang somatic mutations dapat para ma-knock off mo yung RB. Okay? So ano bang ginagawa ng RB? So i-detalye natin siya dito, hindi sa chapter 6, no? So in the presence of under normal conditions, if you have growth inhibitors, no, it will produce your P16, 'di ba? Natatandaan niyo yung P16, saan ko yan binanggit madaming beses, no? Binanggit ko sa chapter 15 sa head and neck cancers, binanggit ko sa male reproductive, no? So yung P16, it's a tumor suppressor gene product, no? So it will inhibit your cyclin-dependent kinases. If you recall your biochemistry, your kinases are enzymes that transfer phosphate groups, no? And therefore, if you inhibit your kinases, then walang mapupuntang phosphate sa RB. Now, if the RB protein is hypophosphorylated, it will remain bound to your elongation factor 2F, and therefore transcription is halted. But if you have RB loss, then you will not produce P16, no, and there will be no inhibitor of your cyclin-dependent kinases, and therefore your RB will be hyperphosphorylated, which causes it to remove itself, no, from your elongation factor 2F, and let the transcription proceed. And that's the specific mechanism on how it regulates the G1 to S phase, no, of your checkpoint of your cell cycle. So it's a retinoblastoma, no? So recall your chapter 9, your small round blue cell tumors of childhood. So they have small round blue cells, but here in the retina they form your rosettes, no? Your Flexner-Winter-Steiner rosettes, which indicate photoreceptor differentiation. So clinically they will present with a white ROR. How ironic, no? It's a white ROR. That's what you call your leukocoria. And the next common symptom is your strabismus. Okay? Now, for your retinal lymphoma, it's in older patients kasi retinoblastoma, di ba, sa bata. Now, retinal lymphoma, you consider in older patients. The most common is DLBCL as always. And of course, usually naman aggressive naman ang mga lymphomas. No? Now, for your optic nerve, no? Ang optic nerve na edema, if you compress one nerve lang, then that's unilateral edema. But if you have increased intracranial pressure, no, you can have papil edema, bilateral optic nerve edema. So, ano ba itsura ng normal, no? Very defined yung kanyang borders. But here, you see it's swollen, no? And the borders are quite blurred. So, yun ang itsura ng optic nerve edema. Now, ang glaucoma, ang nangyayari sa kanya, nagkakaroon ka ng, because of the increase in intraocular pressure, it causes pressure atrophy, no, in your retinal nerve fiber layer. Kaya, so, nagkakaroon ka ng atrophy noon. And also, you will have a cupped atrophic optic nerve as shown here, no? As shown here in this photo. Now, in children, your children medyo quite compliant pa yung kanyang mata. So, kapag meron kang increased intraocular pressure because maybe of angle closure, for example, then pwedeng lumaki yung mata mo. Okay? And that's what you call your blephthalmos. And if the cornea is also enlarged, then that's your megalocornea. Now, in adults, hindi na masyado. So, nangyayari, nag-thin out yung sclera and the uvea becomes quite visible. No? So, that's what you call your staphyloma. And then, when all of those jazz, no, ay nag-come at your eyes, no, ang ending will be your thysis bulbi. Okay? So, it's an atrophic, internally disorganized eye. No? So, pagka napabayaan yung eyes nyo, ito yung magiging morphologic findings niya. Well, basically, the common theme of this is extensive damage, no? Okay? And that ends pathology. So, kung narating mo ang slide na to, thank you very much, no, for your commitment na tapusin yung material. Kahit alam kong nakaka-drain siya, kasi ako, na-drain din ako. Na-drain din ako nung ginawa ko to. And I'm sure na-drain din ang team because this is one of the subjects na sobrang laki ng coverage. Okay? So, thank you very much. And hindi ko na pahabain ito dahil I'm sure mahaba na ang ginugol nyong oras para sa akin. I just want to end with this quote from Taylor Swift's song na You're on Your Own Kid from her Midnight's album. Yeah, you can face this. So, kayang-kaya nyo yan, top-notch batch October 2023, and I'm praying for all of you na makakross kayo sa other side this October 2023 lahat. So lahat kayo magiging doktor, and congratulations in advance. Stay healthy para makapagpatuloy mag-aral, and stay safe. Always pray and study smart. Thank you!